I'm excited to introduce our first presenter, Dana Blackwell. Dana Blackwell is the Senior Director of Strategic Consultation and brings over 20 years of child welfare and public policy experience to her role at Casey Family Programs. In this capacity, Dana leads Casey's work in California, including statewide programs, initiatives, and systems, and improvement activities. So Dana, we're so excited to have you, and I believe we can advance to the next slide.
Good morning, everybody. Welcome to this inaugural webinar of the Comprehensive Prevention Plan Learning Series. Casey Family Programs is sponsoring this learning series in partnership with California Department of Social Services, Implematics, and Caltrans. The learning series has been designed with county prevention teams in mind, intended to support the development and implementation of your individual county comprehensive prevention plan and services program. The learning series will take place over the remainder of the year with learning forums focused on the readiness domains of California's Family First Prevention Services Program as outlined in ACL 2223. Each learning forum is structured to take place over 2 separate meetings. The first meeting is to educate and promote the understanding of the readiness domain and its applicability to plan development and prevention services delivery. The second meeting will take place 2 weeks later. Although there will be a Q&A portion during the first webinar, we know that questions arise when you go back to your county teams, debrief what you've heard and learned, and have those post-meeting ahas or uh-ohs. We want for teams to be able to digest the information and ask questions in the context and reality of your own county. So the second meeting will be an interactive Q&A session for you to come back, dialogue with the webinar panelists and your colleagues from across the state. Finally, each learning forum will include a panel of local and national subject matter experts. Our goal is to provide you with the most comprehensive information and thinking happening across the country and here in California. So now that you know what you can expect from this TA offering, I want to introduce our speakers for today's topic, getting ready to deliver Family First Prevention Services with a special emphasis on fiscal and funding. Our first presenter will be Dr. Cush Cooper. Dr. Cooper is an adjunct professor at the UCLA Luskin School of Public Affairs, as well as the CEO of Implematics, a consulting firm serving public and private organizations in the areas of foster care reform, LGBTQ youth and systems, implementation science, and leadership development. Second, you will hear from Dawn Winstead. Dawn is a consultant with over 10 years of experience working with states, counties, and tribes on child welfare financing issues. He is a former Deputy Secretary of the Florida Department of Children and Families and former Deputy Assistant Secretary for Human Services Policy at U.S. Department of Health and Human Services. And finally, Claire Anderson. Claire is a Senior Policy Fellow at Chapin Hall, the University of Chicago. There, she guides the states using research evidence in large-scale systems change. She has over 30 years of experience at the federal, state, and local levels to support children and families. Our hope is that today's webinar is helpful and supportive of your efforts. Dr. Cooper?
Thank you, Dana, and thank you for your sponsorship and partnership to date. Hi, everyone. Good morning. So, let me advance my slides. So Dana mentioned that this was the inaugural forum for the learning series. And the learning series is attached to certain readiness domains that we've developed in partnership with the California Department of Social Services. And so they are governance, cross-sector collaboration, fiscal and funding, which is today's focus, program design, service quality, workforce training and development, policy, rules and regulations, reporting, and automation. The learning series itself will be focused on the ones you see highlighted there in that light brown or peach color. So we will be focusing on 1 through 7 for the learning series. All right, so given our focus on fiscal and funding, want to dive a little deeper. So what are the areas under fiscal and funding that require a 4E jurisdiction to be ready to provide comprehensive prevention services, which include family first funded prevention services? So you are going to have to think through what you're going to do with the certainty grants and the Family First Transition Act funds. And Don's going to talk a little bit about that here in a moment. You're going to have to develop cost models and projections for which services you're going to carry forward, existing services you're going to carry forward, both evidence-based and not evidence-based. These cost models have to account for expansion plans for implementation and expansion. You'll have to identify alternative funding sources for federal match and for programs that will carry forward but not be funded by 4E. You'll have to look at your contracts and determine if the existing contracts can effectively support implementation. And if they cannot, what are the expansion requirements? Or what are the new requests for proposals that you're going to have to put out? You'll have to, the 4E agency is going to have to partner with the budget and accounting areas, as well, your own budgeting and accounting areas, as well as the behavioral health agency, to finalize methodologies for rate calculations, especially around evidence-based practices. You're going for the service array selected. There's going to have to be recommendations made for how you're going to propose, how you're going to select providers, how you're going to negotiate contracts, and how are you going to provide ongoing oversight of those contracts. What are the joint written protocols going to look like between child welfare, probation, behavioral health, and in some cases, public health and health services? Which sector is going to pay for which service? And what enhancements are going to be needed to existing reimbursement and payment processes so for administrative and provider activities, considering the new Family First administrative and service reimbursement opportunities. Okay. In addition, you're going to have to think through at some point how you know when automation comes online, what your local interface is going to be and how you're going to submit claims. And you know, what are you going to, with regard to claim submission, who are the responsible parties to manage the claims and submissions, deal with overpayments, underpayments, etc. It seems like a lot, but you do a lot of this now in other areas with regard to other service delivery. So it's a new leg of service delivery we're adding to our service array, but we do have some precedent in doing it for non-prevention services. And while it is a lot, and some of you may be wondering, oh, geez, it seems complicated. Why bother? Prevention is where things are headed. The research is starting to show us over and over and over that when we invest upstream, we end up saving a lot of money, saving a lot of goodwill, and being able to support our communities with a strength-based model rather than a deficit-based model, which is when something has to go wrong for you to get services. So this is where the train is headed, and we in California can either get ahead of it or be at its effect. So, but before we dive deep into the land of fiscal and funding, and I turn it over to Don, I want to emphasize the points on this slide. Before you can do any of that readiness work that I just rattled off in the last slide, these 4 things have to happen in the 4E jurisdiction. Okay, so in counties and tribes. So, you know, and I'm going to talk about the 4th bullet first. Who is going to have to establish now? Who is going to be your cross-sector oversight body for prevention, right? All of prevention, not just the tertiary prevention, but primary, secondary, and tertiary prevention. I'll go into what I mean by those in a moment. But it's not just for the families who are just really close to being embroiled in the system, right? It's services for families who might be more upstream. So some of you have your interagency leadership teams from our AB 2083 initiative, right? And you may be thinking of using those. Some of you have prevention cabinets, and you may be thinking of using those. Some of you may choose to not use an established body and use some hybrid of existing bodies. Whatever you choose to do, that body needs to be identified and at least invited and confirmed before you can embark on any of what you're about to hear. So then once that cross-sector oversight body for prevention has been established, then the first 3 things they need to oversee, consume, and then make strategic resource allocations around are, do you have a local scan or inventory for all services that are relevant to prevention? So these may be evidence-based practices. These may be non-evidence-based waiver and non-4E waiver funded prevention services. If some of you were waiver jurisdictions, you might have some that were funded by the waiver. And these local scans or inventories need to include what's the funding source, both the agency and the stream. What are the costs? What are the outcomes? Where the location of these services? And what's the capacity of existing providers? What's utilization and engagement outcomes looking like now, right? And these scans have to be done across, at the very least, child welfare, probation, and behavioral health. Although I can't emphasize enough, having public health and health services at the table and education also will really be worth the investment later, especially if we really care about healthy communities. Right, so your service scan. Then parallel to that, some estimates have to be created of the number of children and families in your jurisdiction that are going to need prevention services, right? And it would help to know what their substance abuse, mental health, or in-home support needs are. There are family first candidacy subgroups that the California Department of Social Services has put forward in their plan to ACF. Well, which ones do you think you might choose? And how many of those candidacy subgroups do you have? And what are their needs? Right? And then when you've got those 2 pieces of the puzzle, you put them together and go, okay, so we're going to match our services to our local population needs and cultures, and the gaps will show up. And then we'll have an implementation plan around filling those gaps. So if you're, particularly if you're from the fiscal and funding area or the data area of your county or tribe, you may want to first inquire into where these activities are being generated and what stage they're in before you dive into anything around for reimbursement or claiming, right? Your cost models are going to be dependent on the outcomes of these activities. How many do we have? Where are they? How do we want to serve them? Etc. So I'm gonna, let me back up one. So I'm gonna turn it over now to Don Winstead. And you know, the one thing I say about Don, and he's heard me say this, is he's likely the only person on the planet that could explain US federal financing to my late grandmother and actually have her understand it. So I'm going to turn it over to you, Don, and take it away.
Great. Thank you, Cush. Appreciate it. And good morning to everyone. It's good to be with you this morning. Let me start with kind of the problem that Family First was trying to deal with, simply stated. So when you think about traditional Title IV foster care, the primary focus historically of 4E foster care was on out-of-home care. So the original thought was when children must be removed from the home, then the federal funds will be available to match state and local funds in order to offset the cost of that out-of-home care. And while there was some limited administrative funding for children at imminent risk of entry into out-of-home care, the primary focus was children who were removed. And earlier, in earlier years, there was a lot of sense in places that if children were at risk, the best thing to do was to remove them and place them in a safe location and to pay for that through Title IV-E federal funds. And as things have evolved over time, there's a growing recognition, as Cush was saying, that the primary focus now in child welfare should be, first of all, to provide services to prevent removal, and that if children can stay in their own home with services without compromising safety, then that is preferable. But 4E foster care funding particularly was out of sync with the way those goals have been emerging and the current thinking in child welfare, given all the research and all the information that we now have. So the Family First Prevention Services Act moves us toward a policy and funding situation that is more in alignment with good child welfare practice. Doesn't solve every problem that we may have, but improves the alignment with good practice in terms of funding. So next slide. So what we're going to start doing today, if you think about, and particularly if you think about this from a fiscal and technical perspective, the little clump on the left is sort of what it felt like to me the first time I encountered all of these new policies and procedures and requirements. Just a lot of stuff there. And what we're going to start doing today is take that ball of yarn and unspool it kind of one thread at a time and try to take it a little bit slowly through a process to say, what are the elements? How do we combine those elements so that at the end of the day, after today and after the other sessions that are in this series, hopefully you can get to a point where you've got a more braided and logical way to move forward in your implementation of Family First. Next slide. Whenever I talk about funding and in child welfare, I want to make a key point at the beginning that's important to keep in mind. Sometimes when we focus on funding, we get so focused on that we forget that the goal is not to optimize funding. Funding is like gas in the tank, but our goals for children and families, our vision and our goals are the key thing. That's like our GPS setting. If we have a good GPS setting, but we don't have gas in the tank, we got a problem. But if we got a full tank of gas, but don't know where we're going, we also have a problem. So it takes both, But the most important thing is having a clear vision for children and families in our area and goals to get there, so that as you work on the financial side of this, every once in a while, step back for just a minute and remember, what are we trying to accomplish? What are we trying to do with children and families in our county and in our area? And then the funding becomes an instrument to make that happen. Next slide. So I want to start with a couple of slides just to kind of orient folks as to what's happening around the country and what we are seeing in terms of implementation. And I think, as everyone knows, in order, oops, back please. There we are. In order to begin implementation of Family First, the first key step in that is to submit a Family First prevention plan to the Administration for Children and Families and the Children's Bureau. And this map and chart shows where things stand today. There are 64 jurisdictions in the country that are eligible to submit prevention plans. This includes states, the District of Columbia, 2 territories, and some tribes who are direct 4E funded tribes. So far, of the 64 jurisdictions that are eligible to submit plans, 47 have submitted plans and 17 have not. Of those 47, and California is one of those 47, of course, but of those 47, 24 jurisdictions have been approved. And you can see from the map, the darker green shown there are the approved jurisdictions. And then in the little bar to the left, you see that the Eastern Band of Cherokee Indians from North Carolina have also submitted and been approved, and the Salt River, Pima, Maricopa County Indian community has also submitted and been approved. There are 4 other tribes who have submitted, and Puerto Rico has now submitted. So this is where we stand today. And so as California continues with the process, there are an increasing number of jurisdictions that are making progress towards approval, some that have been approved, and some of those are going to be things you can look to get ideas about things that other folks are doing that may be relevant to California. Next slide. So since we're going to focus a little bit on money today, here's where things stand from the latest information posted by the Children's Bureau. Now, what happens here is every quarter, based on information that counties send in to CDSS, every quarter the state agency submits a quarterly financial report to the feds. For foster care, for adoption assistance, guardianship assistance, and now also for Title IV-E prevention services. The latest year that the feds have posted that information, they do an annual accounting and summary of that. And the latest year that they posted that is federal fiscal year 2020, which was the first year for prevention services funding. And this shows that first year of claiming. And you can see that Arkansas, DC, Kansas, Kentucky, and Utah were the first states to claim Title IV-E prevention services. The amounts were modest. And you can see that the total, this includes federal and state share, was a little over $15 million, and the total number of children served less than 1,000. So the key point of this, other than now the claiming has started, is that this is not like turning a spigot and all of a sudden funds rush out. I think the claiming process takes a while to get fully ramped up, and this is at least a beginning. The next slide So this just gives a little bit of later preview. In addition to the claiming reports that the feds do, there's also a report that they do on grant awards that go out to states. And this gives what happens. Those of you who are involved in the technical aspects of claiming may know that there's a rolling reconciliation. So every quarter, the state agency says, here's what we estimate will be needed next quarter, and they get a grant award, and then they report on what was expended last quarter, and there's a rolling reconciliation of that. This is based on the grant award system and shows this is just the federal share of dollars. And if you look at the 2020 in the green and the first 2021 and in the first 2020 column under the 2021 kind of salmon color, there is kind of the federal share of that 15 million that was shown on the previous slide. But the key thing there is there have been about a dozen states now that have now in 2022 begun claiming. And again, the amounts are relatively modest. To put it in context, a 2.5 year or 2 1/3 year really total of 96 million. The annual federal share of claims for 4E foster care is over 5 billion. So, again, modest amounts, but you can see that slowly this is ramping up and we're starting to see claiming going forward. Next slide. So in addition to the 4E funding, the Family First Transition Act was passed a couple of years ago to provide some transition funding, and I'll just highlight a couple of things from that. First, there were funding certainty grants. These are grants that have a guaranteed minimum funding for the jurisdictions that used to be Title 4E waiver jurisdictions. So the idea there was that when the waivers ended, that the first year after the waivers ended in federal fiscal year 2020, that jurisdictions would be guaranteed not less than 90% of what their capped allocation was in the final year of the waiver. And then in federal fiscal 2021, they would be guaranteed not less than 75%. So for those former waiver jurisdictions, if they're claiming their regular 4E claiming was below those levels, they got that guarantee. Those funds can be expended until September 30, 2026. So they have a little bit of life to go. So if you're one of those jurisdictions and have some of those funds remaining, you've got until the end of federal fiscal 2026 to expend those. In addition, Congress appropriated $500 million nationally for Family First transition grants. These were a one-time grant to ease the transition to Family First, and they can be used for any activities that are allowable under Title 4B of the Social Security Act, any purposes that were allowable under a former 4E waiver, or any activities directly associated with implementing the Family First Prevention Services Act. So there's a lot of flexibility with these funds, and also the Title 4B uses. There normally in Title 4B, there are some restrictions on the percentage that you can spend on maintenance or the percentage you can spend on administration. Those restrictions do not apply. So Cush will later talk a little bit about how that worked specifically in California, but those funds are available until September 30th, 2025. The total California allocation was 49.1 million for that. So those are some additional funds that we've seen in Family First world to help jurisdictions transition from where we are now into a Family First. Next slide. So when we talk about Family First, I think about Family First in three big pieces. It's a puzzle with three big pieces. And Prevention services being one of those big pieces, non-family settings being another big piece, and then timing, including all of the reporting and planning kinds of things that you have to worry about. Now, with the non-family settings in the red, that's not really the focus of today's presentation. Glad to deal with any questions that folks may have about that. These are the, when we talk about non-family settings, the so-called specified settings like QRTPs and other specified settings, and also residential settings for children who may be placed with parents in family-centered substance use treatment programs. So those kinds of things. But we're focused primarily today on prevention services, and also a bit about some of the timing considerations that go into Family First. Now, in terms of prevention services, they're going to focus and spend a good bit of time on candidacy. There's some subtlety to candidacy and some new things. Of course, candidacy is not new, but there are some new aspects to candidacy under Family First. We'll talk a little bit about approaches to evidence-based programs. I know in later sessions, there'll be a deeper dive on service design and evidence-based programs, but touch a bit on that, particularly as it relates to some of the fiscal aspects of that. We'll also talk about, I'll talk about, and Cush and our colleague Claire Anderson will also talk more about broadening the prevention lens, moving upstream and thinking more broadly about prevention than perhaps we've done in the past. Kinship Navigator, and there's kind of asterisk there. I'm not going to go a lot into Kinship Navigator. There are some things to come in the future that I just want to mention, and it's not within the prevention services domain specifically, but there are some things just to make mention of. And then also post-permanency candidacy. And I guess the key thing to emphasize there is when we talk about candidacy, there's a tendency, in fact, on some of the federal claiming forms, the term that's used is pre-placement candidates. And the notion there from that term is that a lot of the focus historically on candidacy has been upfront and before a child enters foster care for children who are at imminent risk of entry. But Family First makes very clear and very explicit that children at risk of foster care entry can include children who are at risk of re-entry to foster care. So this could include children who have been reunified, but may be at imminent risk of return to foster care, children who have been adopted, including children who have been adopted who may be receiving Title IV-E adoption subsidy, who may be at imminent risk of having a return and having disruption in that adoption. And it could be children who are in guardianship situations who may be at imminent risk. So just to emphasize that candidacy not only is upfront, but also can include children at imminent risk of re-entry into foster care. Next slide. Okay. Of course, candidacy is nothing new for California. And if I remember correctly, some of you, when I say candidacy, will shudder a little bit because of some prior experiences with it. And you're not alone in the country. Candidacy can be fairly technical, and you got to make sure your ducks in a row. This slide compares traditional candidacy, that is candidacy as it existed before Family First, with Family First candidacy. And there are different sections of the law that govern these two situations. And I'll spend just a minute on this. Traditional candidacy, the term in the law is children who are at imminent risk of removal. And the Family First candidacy uses a slightly different term, but essentially the same thing. children who are at imminent risk of entering or re-entering foster care. The traditional candidacy is children where the imminent risk is identified in a defined case plan, or 4E eligibility has begun, or they're identified in a court order with certain language in the court order. Whereas for Family First candidacy, there it is a child who's identified in a Family First prevention plan as being in need of prevention services as defined under Family First and at imminent risk. For traditional absent prevention services, foster care is the planned arrangement for the child, where in Family First, the service needs are directly related to the child's safety, permanency, or well-being. Traditional candidacies renewed every 6 months. Family First candidacy is for not more than 12 months. However, if at the end of 12 months, you make an additional determination that more time is needed, then there can be additional 12-month periods, including contiguous 12-month periods. So there has to be a reassessment at the end of 12 months, but it can be for a longer period of time. The key thing with traditional candidacy is it doesn't cover services. So services, social services, counseling, therapies, all of those things are not covered under traditional candidacy. There is coverage for case management or other administration. It is matched at a 50% rate, but that is subject to the discount rate for foster care. So it's 50% times the participation rate or discount rate for foster care. Whereas Family First services that are, and we're talking more about this, but services that are evidence-based that are listed on the Prevention Services Clearinghouse are matchable at 50%. The restrictions, of course, are they have to be listed on the clearinghouse, and we'll go into some of the other restrictions. The other big deal there is that administration, including case management, is matched at 50%, and it is not subject to the 1996 AFDC eligibility requirement, which normally applies to traditional 4E. So it's a full 50%, not 50% times discount rate, but full 50%. Then the last row here talks about the CWPM 8.1D does not apply or does apply. That refers to a specific section of the Child Welfare Policy Manual. And in the next 2 slides, I'm going to just briefly cover what that includes, just to orient you and remind you of those requirements. So next slide. So again, this is not applicable to Family First candidacy. This is applicable to traditional candidacy. In the Child Welfare Policy Manual makes clear that the term imminent risk or serious risk is that serious risk or imminent risk are synonymous, but that a report of child abuse and neglect is insufficient for establishing candidacy. So in other words, it is serious risk or imminent risk is not fulfilled by the child merely being the subject of a report of abuse or neglect. It has to go further than that, and that has to be documented. In fact, the Departmental Appeals Board that ruled on this indicated that the fact that a child is the subject of a report falls far short of establishing that the child is at serious risk of placement in foster care and thus becoming eligible for 4E. So that's kind of the traditional view, is it has to be more than that, and that has to be documented. Next slide. Then the way that it has to be documented, there are 3 things in the Child Welfare Policy Manual that indicate how it's to be documented. First, a defined case plan that indicates absent effective preventive services, foster care is the planned arrangement for the child. In other words, here are things that are going to happen, and without them, the child's coming into foster care. Secondly, an eligibility determination form has been completed to establish the child's eligibility under 4E. And the thinking there is that you wouldn't normally do a 4E eligibility determination unless you were seriously contemplating the child entering foster care. Or third, evidence of court proceedings in relation to the removal of the child from the home in the form of a petition to the court, a court order, or a transcript of the court's proceeding. So at least one of those three things has to be in place to document the imminent risk or serious risk of the child in traditional candidacy. Contrast that with 4E. So next slide, or with Family First. Family First in the guidance, and this is out of the Program Instruction 18-9, which is the guidance from the Children's Bureau related to candidacy. They made clear that they are not further defining what the phrase candidate for foster care means, and they're not further defining the term imminent risk of entering foster care. So essentially what they've said is it's up to the state 4E agency to say what imminent risk means, and therefore who meets that definition and is therefore a candidate for foster care. So this is the policy guidance that potentially allows moving further upstream and having a broader definition of imminent risk than what is the traditional Title 4E definition that's covered under the policy manual historically. There is one thing, though, that they've emphasized, and that is that the technical definition of what it means to be in foster care means that the child is under the placement and care of the state Title 4E agency. And that applies whether or not the child's in a licensed setting or unlicensed, whether or not the care is paid or unpaid. So if a child is under the placement and care of the Title 4E agency, then by definition, the child is in foster care. And because a candidate is a child at imminent risk of entering foster care, then if you're in foster care, you can't be a candidate because you're already in foster care. So that's a definitional thing that the Children's Bureau has clarified. So even though a state has broad flexibility now to define what is imminent risk and who is a candidate, then the one restriction is that cannot be a child who is in foster care, whether paid or unpaid, licensed or unlicensed. Okay, next slide. So this is a kind of a graphic attempt to kind of illustrate where that leaves us in terms of traditional candidacy and Family First candidacy. So the blue there in the circle, the kind of the Venn diagram, suppose you define candidacy more broadly than traditional candidacy. Now, if a child meets a traditional definition of candidacy, they're likely to also meet the Family First definition, but you can have a broader definition of candidacy under Family First. So if the child's imminent risk definition is broader, then in order to be in order for the prevention service to be matchable under Family First, then the child would have to have a prevention plan that includes at least one evidence-based program that's found, or evidence-based practice found on the Prevention Clearinghouse. If the child doesn't have an evidence-based program or service as found on the clearinghouse, then the child could be a traditional candidate, but they would have to meet the somewhat more restrictive definition of candidacy under traditional candidacy for that to be, and then you couldn't claim services, but you could claim traditional administration, including case management, subject to the discount rate. So to kind of illustrate that, I've got a couple of examples just to see if I can make that point going forward. So click. So suppose a child meets the traditional 4E definition of candidacy. Her case plan includes payments for rent and utilities to stabilize the family and prevent removal, but these are not in and of themselves listed on the Family First Prevention Clearinghouse. Click. In that case, the child is a traditional candidate. The prevention services are not paid by 4E, but administration, including case management, are reimbursable at 50% times the discount rate. Next example. So suppose the child meets the broader Family First definition of candidacy, and her prevention plan includes one or more evidence-based programs listed on the Prevention Clearinghouse and are in the state's approved Family First prevention plan. Click. Then this child is a prevention candidate under Family First. The prevention services listed that are the ones listed on the clearinghouse are eligible for 4E payment at 50%, full 50%, and administration, including case management, is reimbursable at 50% without regard to the discount rate. So full 50% there. Okay, next. Suppose a child meets the broader Family First definition of candidacy, but does not meet the traditional definition. Her prevention plan includes payments for rent and utilities to stabilize the family and prevent removal, but these are not included on the Prevention Clearinghouse, and the plan doesn't include any clearinghouse approved prevention services. In this case, click. The child's not a traditional candidate because she doesn't meet the traditional definition of candidacy, and she's not a Family First candidate because her prevention plan doesn't include a Family First prevention service. Therefore, neither the services or the administration are reimbursable under 4E, although there may be other funding sources that you have that would pay for that, similar to currently children who are not 4E candidates. Next slide. So when we think about this and the experience of states going forward, is it Family First candidacy or traditional candidacy or some combination? And this is where, at least for a while, very likely you're going to have your cost allocation plan and your tracking capacity, et cetera, set up to differentiate both of these and be able to claim traditional candidacy and Family First candidacy. So for example, from the first states that were the first 5 states to claim prevention services in federal fiscal year 2020, one of those states, Arkansas, has not in recent history claimed traditional candidacy. Arkansas was a statewide 4E waiver site, so they haven't claimed candidacy specifically for a while, if ever, and have started to claim some Family First candidacy. The other 4 jurisdictions, however, are claiming both. They are claiming traditional 4E candidacy using traditional methods, and also, in addition, claiming Family First prevention services. Now, the District of Columbia, they are a jurisdiction that has made rapid progress with claiming, and in talking with them a couple of weeks ago, My understanding is by the time they complete their claiming for federal fiscal year 2022, the year that we're in now, by the end of this year, they're going to be claiming fully family first candidacy and not traditional candidacy, because through their use of particularly motivational interviewing, they are essentially, every child that they're serving will be a family first candidate at imminent risk under their prevention plan. But it takes a while to get there. Some other jurisdictions may not get there for a while, or if ever, depending on how broadly their family first prevention plan defines imminent risk, and also depending on what prevention services they have built into their plan. Okay, next slide. So prevention services, the key to prevention services is candidacy. That this is, prevention services are available to candidates or children in care or youth in care who are pregnant or parenting. And the prevention services include, and I think everybody who is involved in implementing Family First is probably used to this, but the services include mental health and substance abuse prevention and treatment services, in-home parent skill-based programs, including parent skills training, parent education, individual and family counseling for not more than 12 months, unless there's a redetermination determined that an additional time is needed. For candidates or children in foster care who are pregnant or parenting, the services must be trauma informed and provided in accordance with promising, supported, or well-supported practices. Next slide. So this shows kind of where things stand as of now. The Clearinghouse has been adding programs to the list. In general, about once a quarter, they'll update the list. The last update came on May 31st, and now they have evaluated 98 programs, in total. Of those, 14 have been determined well supported, 14 supported, 25 promising, and then 45 not meeting criteria. And of course, some have been evaluated in multiple domains. Next slide. So this slide just shows the well-supported ones and what they are and when they were evaluated. And then you can see the last column to the right there, the current, at least the last one I've seen of the California draft prevention plan that was submitted shows the ones that are included in the California plan. And of course, I think at the time they were submitted, those were the 10 that were the well-supported evidence-based programs. And since then, 4 additional ones have been added. But that at least is currently where things stand in terms of the California plan. And if that's been updated since then, I think someone will update me as we go along. The next slide. So in terms of prevention services, at least so far, this won't apply significantly to California, because all of the prevention services that California have proposed are well supported. And of course, the advantage, or one of the advantages for proposing well-supported practices, is there is a provision in federal law that if you propose a supported or promising practice, you have to, in addition, do an evaluation. With well-supported practices, you can propose to waive the evaluation requirement because it is well-supported, but it requires a waiver for each one by the feds. Under Family First, there is a provision so that the funding is affected by the rigor of the evaluation, and at least 50% of the reimbursement for prevention services, at least 50% of the federal reimbursement, must be for services that are well supported. Then the Family First Transition Act suspended this requirement for a couple of years, and then delayed enactment and allowed supported to be treated as well supported for funding services. And then that comes back into effect in federal fiscal 2024. The key thing here is since California has proposed well supported, right now this won't matter. It won't be a limiting factor to California unless in the future you propose supported or promising practices. And of course, in 2027, the federal matching rate for services changes from 50-50 to the FMAP rate. But since California's FMAP rate is 50-50, then unless your federal medical assistance percentage changes, then California will remain 50-50 for services. And of course, the administration remains 50-50. Next slide. Now, this shows the duration of the prevention services and administration. For services, as I said, the rate is 50% and then changes in October 1, 2026 for states that have a higher FMAP rate. Administration, 50%, and you can take administration basically divided into two subcategories: child-specific administration and non-child-specific administration. For child-specific administration, which would include assessment, case management, all of those kinds of activities, this begins the first day of the month in which the child is identified in a prevention plan as being a candidate, or when the child is identified as being a pregnant or parenting youth. But for candidacy, when the child is identified as a candidate in the prevention plan and in need of a Family First prevention service, then administrative claiming begins from the first day of that month until the end of 12 months, or if services are provided for less than 12 months, to the end of the month through which services were provided. And at the end of 12 months, if additional time is needed, then there's another determination can be made and additional time can be provided. Non-child specific administration is from the first day of the quarter in which the state submits an approvable 5-year prevention plan. And I'll talk a little bit on the next slide about what those non-child specific administrative claims can be. And what they say in the guidance is those activities are the same things that are in a particular reference to the federal regulations, but those are the same definition, the same kinds of things that apply to traditional administration. And it's essentially those things that are necessary for the proper and efficient administration of the program. Next slide. So non-child specific administration is activities, can include activities to develop necessary processes and procedures to establish and implement prevention services for eligible individuals, policy development, program management, data collection and reporting, etc. And also training for state and local staff and staff of approved child welfare agencies related to Family First, who's a candidate, how to do it, etc. How to determine who's eligible, how to identify and provide appropriate services, how to oversee and evaluate services, all of those administrative activities and training for those activities that are not specific to a child are covered under child-specific administration, non-child-specific administration. Next slide. Now there is and something that gets a lot of attention, the payer of last resort provision. Got a couple of slides on that, and we can deal with any questions that folks may have about that. But essentially with the payer of last resort, the concept is simple. If a prevention service would have been paid from another source before Family First, then it'll be paid by that source after Family First is implemented. There is an exception to that, and suppose the other source paying for it would prevent the timely provision of the service, then 4E can pay for it and then get reimbursement from the other source. Next slide. So specifically, if a public or private program such as private health insurance or Medi-Cal would pay for a service allowable under the prevention program, then that same source has the responsibility to pay before Family First would be required to be paid. So if Medi-Cal would pay for a mental health or other service prior to Family First, then after Family First, they would continue to pay for that. And 4E could pay for something for someone who was not eligible or for service that would not be paid under Medi-Cal. So the basic requirement is what would happen before Family First, and if Medi-Cal would pay for it before Family First, then Medi-Cal pay for it afterwards. If Medi-Cal would not, then 4E can, assuming it's an allowable service. Next slide. But in addition to that, even if the prevention plan is the service is being provided but paid for by another source, such as Medicaid, then if there are 4E administrative costs, such as case management, 4E can pay for those, even though the service is paid by another source. So if the prevention service is covered under Medi-Cal and is paid for that source, but there are 4E case management or other administrative costs, you can still claim those under 4E in addition to that. And that the reference at the bottom just shows you the Child Welfare Policy Manual section that specifies that that is the policy. Next slide. So I won't talk a lot about maintenance of effort, just to know it's there. And essentially this gets worked out between the state agency and the feds. And essentially the concept is that if TANF or Title 4B or SSBG or another state program paid for a prevention service that met all the prevention services criteria in Federal Fiscal 2014, then you have to maintain that effort, and you can only get reimbursement for the new federal funds for services that are provided above that level. So think of it as a bucket, and you pour into that bucket the TANF, 4B, SSBG, or other state program funds provided in 2014 for a service that was an allowable prevention service and activity that met all the requirements of Family First for candidates, pregnant or parenting youth, for an evidence-based program, et cetera, trauma-informed, all of those requirements. The MOE requirement does not apply to 4E expenditures and does not apply specifically to 4E waiver expenditures. The other thing is it's a one-time calculation, and it's based on the evidence-based programs that were on the clearinghouse at the time the state submitted their prevention plan. Once this is established, and once CDSS and the federal agency established this, it's a one-time thing. It never changes in the future. So if new things are added to the clearinghouse, then those will not affect the amount of the maintenance of effort requirement. Next slide. So I said a little bit earlier that I wasn't going to talk a lot about Kinship Navigator, and I'm not, but just to mention that there continue to be under Title 4B Part 2 Kinship Navigator grants. There is a 4E Kinship Navigator program. However, the requirement is that the 4E services have to be evidence-based and on the clearinghouse. And so far, even though there were some temporary flexibility, those have expired now. And so there's only one Kinship Navigator program listed on the clearinghouse, so it's a very limited availability. Next slide. It is separate from the 4E prevention plan. So it's a different amendment that has to be made to 4E. And this just gives some of the requirements. It is today not really a focus, but just keep in the back of your mind that at some point in the future, if more Kinship Navigator programs get listed on the clearinghouse, this could become a more prominent feature in addition to prevention services going forward. Okay, next slide. So some things about timing and the claiming and all. Of course, we know that California has already submitted a Family First Prevention Plan that is currently pending, and I'm sure is the subject of some dialogue going back and forth with the federal agency. I'll mention a couple of things about claiming and reporting, just to let you know some things coming. Next slide. So, of course, counties don't see this, but you submit information into the state, and then the state submits claims to the federal government. And this is the what happens when the prevention services plan for a state gets approved. This part of the online data collection form that the state agency fills out gets unlocked. And essentially what the state has to report is the amount of claims for well-supported practices, for supported practices, for promising practices, and then administrative cost. And click one more time, Cush. And on that administrative costs, the child-specific and the non-child-specific are totaled and reported on the federal system on one row. Then prevention service training costs are reported separately, and then those total costs. And this shows just current quarter claims, and of course there are additional columns for prior quarter adjustments, et cetera, et cetera. And then in terms of the number of children, then there's a requirement to report the total number of children for whom any prevention service is provided. So pretty straightforward, but this is the way that the information is submitted from the state to the federal agency. Next slide. So there are additional reporting requirements. There is a new reporting system. For those of you who are familiar with federal reporting systems in child welfare, There's the AFGARS system, NIDED, the Protective Services stuff is submitted, and there are multiple systems, but there's now a fourth one. A new one is upon us now, and that includes child-specific information on prevention services. And click to the next slide. This just lists the 14 or so data elements that are required as part of this new system. And the agency will have to gather this information from the systems, report it to the federal agency, and you'll see that this is required child-specific information to be reported, and then for each child, the start date, cost of services, the end date, whether or not the child subsequently enters foster care, etc. So pretty detailed reporting required. Next slide. And the good news is that if you look at all this timeline and approval, et cetera, the bottom line is once you start, the state has essentially a year's grace period for meeting this requirement. The first jurisdictions that claim, the early ones, they have just now submitted the first report in May, so this is just now started. But once you are under these requirements, then there's essentially one full federal fiscal year before the requirement has to be made. Next slide. So I'll complete and hand over to my colleagues, but it's just a couple of things there. We talked about broadening the focus of prevention work. I call it back to the future, because when I first started in this business many years ago, we were just then starting to do something they called separation. That is, taking the benefit programs like at the time AFTC and then later SNAP and Medicaid and all, but taking benefit programs and service programs and separating those into two different agencies in some cases, or two different programmatic constellations, as if they were had nothing to do with one another. And I think one of the things we're seeing now with concrete supports and the emphasis there is when you consider that the majority of the reports of abuse and neglect are neglect, and many of those have a significant poverty overlay, that concrete supports and the ability to support families financially is also a part of what is very important to improving the welfare of children and families. So we're seeing some reintegrating and some ideas about reintegrating those at the community-based level. And I think additionally, what we see is a lot of advance in local strategies to take the various pandemic-related funding and special funding and the traditional funding and now Family First funding, and to bring those together to try to better align our ability to help improve the well-being of children and families. So with that, I'm going to turn it over to Cush and to Claire, and for you to go forward. Thanks very much.
Terrific. Thank you so much. Hi, everyone. I'm Claire Anderson, Senior Policy Fellow at Chapin Hall. It's so good to be here. It's always hard to follow Don Winstead in a presentation, given his thoroughness and expertise in the subject. I'm going to try and help zoom out to that that engine that Don talked about earlier, the direction that you're going, the vision that you have. And I asked Cush to stay on this slide for just a moment. In part, before we go to the slide that I'm going to talk about, so that we can connect the dots between this provision of services in the community and the bigger vision and what is in the California Family First Prevention Plan. I believe you all have a link to it. And I'd encourage you to take a look at page 22 that outlines a community pathway for identifying and serving families who could benefit from Family First services, and want to really acknowledge the state and everyone in California for being forward-looking in terms of thinking through the various ways that we can not recreate the system that we have, given that we have a policy designed to be transformational, and in fact create new and innovative ways to deliver services, to resource community organizations to do this work, and to do this work with families in organizations, in communities where they trust that services will be helpful to them. And so figure 2 in your prevention plan really does a lovely job. I actually shared this with states all across the country of articulating and describing visually how a family could come to an agency, a neighborhood association, a school, a community-based organization, another public agency within the state, and the need for services be recognized and assessed for. And then have the 4E agency make the determination of candidacy, and all of the services and supports be provided and available on platforms other than inside the 4E agency. There are, in addition to California, probably 13 or 14 other states that have submitted a prevention plan that includes a community pathway. And I think that this is important for you to know insofar as it helps you understand that not only within California is there forward-looking innovation happening, but that you are in very good company. Many states are negotiating with the Children's Bureau about what a community pathway will look like, what it will entail, and how to get services to families earlier. And on platforms that they trust. So when Don talks about back to the future, it really is, I think, a new opportunity to think about service delivery in an integrated way through community-based organizations, and blending and braiding together the kinds of economic and concrete supports that they have access to through other public entities, along with the availability of funds for Family First services and case management type activities, and services like motivational interviewing. And someone in the chat earlier asked about mindfulness, cognitive-based therapy. So some of these services that can be provided by family resource centers and community organizations. So it's a very exciting time in child welfare, and I think California is on the forefront of that exciting, innovative thinking. So I'm going to have you go to the next slide, Cush, beyond that framing. To help us think about this from a family-centered approach, which is what the community pathway, I believe, is designed to do, to center families in the context of their community and the context of the availability of services and supports in their neighborhood, in their community and social context, in the context of macroeconomic policies and economic stability within families, access to education and quality, and access to healthcare. This is the CDC's Healthy People 2030 framework, and I think allows us to really understand that there are multiple levels in which we might concern ourselves to ensure that families get a comprehensive and holistic array of services and supports that focus on improving and strengthening their holistic well-being as a core impact that emanates from preventing their involvement with child welfare and addressing their needs if they do become involved with child welfare. I think it's also important to note that as we across the country are trying with much greater intentionality to listen to the voice of those with lived experience in our systems and community members, that what we hear often is not only that the need for improving the interface or the family user experience in child welfare, but that there are many missed opportunities or gaps that we could have helped a family address before they came to the attention of child welfare. And I think this framework helps us to understand where and how those opportunities sit and with whom we might be partnering across sectors and across communities to address the needs that we are hearing from people with lived experience in our systems and in our communities. So let's go to the next slide. This also is related to social determinants of health, but I will say to you and this is from a framework from 2010, and I think we'll have that link dropped into the chat for you so that you can go and review this framework. It's a little complicated. There's a line in there that said that in the development of this conceptual framework, the core lesson of the working group that created it was that intermediate determinants of social determinants of health cannot be our sole focus. The behaviors, the psychosocial factors, the space in which we in child welfare often focus our interventions, that those cannot be the sole focus, that we must also be concerned with the structural determinants of determinants of health, to include our governance structures, our macroeconomic policies like our child tax credits, our paid family leave, our universal child care kinds of policies, social policies related to land use and housing availability, affordable housing, our public policies in health and education, and our cultural and social values, that these two must also be part of our framework for addressing social determinants of health. And I would argue that the inclusion of child safety, child and family well-being fits quite nicely in us understanding this holistically. And it does not escape any of us that the majority of the family first services fit in this intermediate determinants. They are interventions designed to intervene with perceived problems at the individual or family level, and do not take into account the contextual or the structural determinants. And I think that's where our broader thinking and our broader partnerships and our broader strategies to work upstream, to partner across sectors, to be concerned about macroeconomic policies must come into play for us to create a holistic prevention strategy that truly meets the needs of families and truly addresses and achieves well-being and thriving for children and families. Okay, next slide. So I'm going to transition from the big macro level back into family first for a moment. Because in addition to thinking about getting, in part because home visiting sits sort of in this interesting middle space. Home visiting programs, as you well know, many of them that are part of the maternal and infant and early childhood home visiting evidence-based programs and are funded, have their own funding stream, are also available within the Family First Clearinghouse, and Healthy Families America, Nurse Family Partnership, and Parents as Teachers, as well as Family Checkup for Children, are well supported on the Clearinghouse, and Family Spirit is promising. Many of these home visiting evidence-based practices were designed and intended to prevent child abuse and neglect from occurring. And in order to do so, that means that prevent means prevent. We prevent child abuse and neglect from occurring as a core strategy within Family First. We often think about Family First services only if child abuse and neglect has happened. But these interventions do this really interesting thing, is that they work both in the preventing child abuse and neglect from happening the first time and in a secondary way as well. They also, many of them, are quite focused on linking families to the broader social service safety net, to economic and concrete supports, and concern themselves with ensuring that the context, as we were just talking about in the social determinants of health, are addressed as well. So as you think about your service array, as you think about, as Cush talked about early on, about understanding the likely population of candidates in your county, think very strategically about families with young children that have some risk factors for involvement with child welfare, who are likely eligible for these home visiting programs implemented as intended to prevent child abuse and neglect, with whom they were intended, which is often families who are much further upstream than at the brink of foster care. You'll also note on the right-hand side of this chart that many states, many states are using these as a central part of their Family First plan. Certainly not solely, but kind of anchoring their plan as a mechanism by which it's possible to move upstream. Also, it's important to note in the statutory language of Family First that it says that we're to prevent entry to foster care through the evidence-based practices. And that, thinking about it in that way really does help us frame up where there might be new or different opportunities than were conceptualized in 2018 when Family First was initially passed. I would encourage you to really partner with your home visiting partners in your county to think about how Family First home visiting will be delivered, if it will be where and how along your continuum of risk it will be delivered, and to have those conversations early and often. There are certainly numerous challenges with funding. McV funds slots of home visiting, and Family First funds candidates and service delivery that are provided to those children and families. And certainly I don't believe have fully worked out the payer of last resort in the home visiting space, but it is an important area to keep your attention on. Okay, let's go to the next slide. Great. And I think I turn it back over to Cush here. Is that correct?
That is correct. Okay, so it is exciting, as Claire has emphasized. It is innovating, and we are finally getting to provide services to families we always knew were needed before they got to us, right? And for me, it's a relief that we're going to be able to stop tinkering around the edges, and really provide services to families when they need them, not when they come to our attention, which is way after harm has already happened. So when I was asked to support the implementation of Families First Prevention Services in California, and those included sort of a comprehensive view, and I'll get into what a comprehensive view of prevention entails. I asked, well, show me what it is that you need help implementing. I'm in. And what I found was that while we had an idea of what it could look like, there really wasn't anything that anybody had put down on paper. Like nobody could say, here's a guidance manual, or here's a picture for a comprehensive prevention services program, of which Families First funded services are a portion. So I started to lay one down in order to get my arms around, well, what is this thing that we're implementing? So a comprehensive view of prevention includes 3 tiers, okay? Primary prevention, secondary prevention, and tertiary prevention. Okay, I'm going to get into what those are. I'll just say first, before I show you some slides, that we in child welfare, in probation, and even to some degree behavioral health, although less so, have been working in the area of tertiary prevention. Okay, and when I show you the slide that goes with that, you'll see that. However, I don't want to anchor the conversation there. I think I've said in a prior talk, I need us to pull up the anchor from where we have been providing services, and I want us to re-anchor ourselves in primary prevention. So what do I mean by that? All right, so you could imagine if primary, secondary, and tertiary tiers were these concentric circles, your primary prevention area is the largest outermost circle. It's also sometimes called universal prevention because these are, and Claire touched on these are things that all families, your family, my family, all families need to have well-being, okay? And a lot of what families need to have non-system generated well-being, so to speak, are these universal services. And we can anchor these in the social determinants of health. You are preventing different things at each tier of prevention. We talk about prevention in using these broad strokes, but we're never clear about what is it that we're preventing. Well, are we preventing child maltreatment? And when are we doing that? Are we preventing foster care? Well, then when are we doing that? Of course, preventing child maltreatment would inherently prevent foster care, we would hope, but they are different. You're preventing different things. So at the universal or primary level, right, your goal is preventing communities from becoming unhealthy places to be and to work and to play in the first place. Okay. And so in the area of economic stability, what would we all need to have well-being? Well, we need to have, a way to bank and store our money. We need access to job training and job placement. We need food security. We need quality childcare. We need to be reasonably financially literate inside of this system in which we exist, this country in which we exist, and we need affordable housing. We all need that. And education, in the education area, support with high school graduation, right? Sometimes families can provide that. Sometimes families can't. For example, families where the parents are first-generation immigrants. The children in those families may not have the same conversations at the dinner table readily that those of us that may have grown up fully in the United States and had a sort of a middle-class upbringing would have. But so that's what's needed. Access to higher education, college counseling and support. Access to literacy, and if I'm not, English is a second language for me, then some support with getting up to speed with English. Early childhood education, quality early childhood education. What might that look like? Universal preschool, universal childcare, and then a basic awareness, right, of child development. Like a basic awareness of what it takes to be a parent of a regularly developing child. Right? Health and mental health. What might you and I need? Well, we need access to primary and mental health care. We need access to emergency and urgent care when we need it. We need to be literate with regard to health and mental health, with awareness and education in our communities all around us. Regular developmental screenings for our children, prenatal care for our pregnant folk, and then just general access to wellness and well-being, like mindfulness, right? Neighborhood and lived environment, access to nutritious food and grocery stores that provide that, access to quality housing, right, where there's no mold, there's no pests, community safety that fits with what our community needs. And that includes mutual aid programming around community safety, and then basic clean environment and sanitation, right? And then for social and community context, access to civic participation. We all need that. We all need to feel like we're efficaciously supporting and advocating for ourselves. And we all need supportive social networks so we don't become isolated. This is what a family would need. And if communities, and this is something that healthy communities can provide for families, okay? So if we anchored here, right, we really are able to start to provide those things that we all know are needed for those families that ended up at our doorstep in child welfare and probation. We've seen studies of what themes were common with folks that ended up in child welfare or probation. And you'll see that there were breakdowns in these areas for these families long before there was risk, and that's because they were living in unhealthy communities. And so now it has to become the goal of, we need to put our money where our mouth is with regard to working ourselves out of a job, right? Child welfare, probation, mental health, right? This is now all our wheelhouse, right? And that cross-sector governance group that you're going to create needs to be able to address these areas, right? So start thinking, okay, well, geez, who would I need to have at the table? I just thought it was going to be the usual three: child welfare, probation, and behavioral health. Okay, so primary or universal prevention. Now, why do we end up tinkering so much in sort of more downstream areas? Well, this is a lot to do. It can seem really overwhelming to support healthy communities. And so we just throw our hands up and say, well, you know, we don't have any control over poverty, so we'll just tinker over where we're, you know, where we know what to do, right? But that means that in some ways, if we ignore these areas, we are not working ourselves out of a job. In fact, we are securing our job, because we know that breakdowns here, we don't address them, are going to have families be at our doorstep. So that's our first goal, right? Is have our communities support our families, not our systems. So our communities have to be healthy in order to do so. Okay. We're not going to be 100% successful doing that ever, right? Even if we anchor ourselves there. So what happens when we are unable to get a community be healthy, right? What happens to those families now in unhealthy communities? Oh, now we're in the next concentric circle in secondary prevention, and it's called selected prevention because it is targeted at a select population, those who are at risk. So now at this level, you're not preventing unhealthy communities. That's already happened. So now the community is unhealthy and the folks that live in it are at risk, right? So our goal now is preventing harm for those now at risk for harm because we did not support health in the communities in which they live, right? So goal, preventing harm for those now at risk. So I'm not going to read these all. You'll have these slides, but just touch on some of these. So for folks now in communities that don't promote economic stability, what are you going to need to have to add to those primary service array? Well, you're going to have to add cash supports for folks who are now under the poverty line. You're going to have support for the unemployment that results from not having access to adequate job training and job placement. You're going to have to deal with things like food banks and other ways to deal with food insecurity or Meals on Wheels. You're going to have housing supports and subsidies because of the lack of affordable and safe housing. And you're going to have to connect folks to TANF-based services, right, that support folks that have dipped beyond the poverty line. Similarly, what would you add now in the education area to those primary strategies? You're going to need alternative or continuing education. You're going to need vocational training programs for those that have not had access now to the more traditional education parts. You're going to need special education services for children who are now displaying education issues because they lived in communities where the schools weren't able to support their academic achievement, or schools in which there were educational stressors, right? Or families in which there were stressors. And you're going to need the kind of parenting education that we're used to providing, sort of as you start to get further downstream, which is how to deal with children that now have issues, for example. Health and mental health. Now you're not in prevention, you're now in early intervention. You're already starting to see some health and mental health consequences in people because of the lack of health in their communities. Neighborhood and lived environment. You're going to have to now start to make sure that we've got ways to do restorative justice, because in unhealthy communities, there's crime. because there have to be economies that have had to get set up because those populations haven't had access to our traditional economies. They've had to build their own. Sometimes those don't fall into things that are legal, right? But so then fair housing advocacy and environmental advocacy services for folks that now live in unsanitary environments, for example. And then from the social and community aspect, you're going to need crisis lines. You're going to need wraparound services, home visiting, respite care. So those are things now you have to add to that slide I just showed you. So you're on your way to becoming comprehensive, right? You've got the universal tier and services there. They might look a little different. And there might be different volumes of these services in different jurisdictions, but in general, you're going to need these service areas, right? So now imagine we've failed yet again. We failed to prevent harm for those at risk. And what has happened? Well, when you fail to prevent harm for those at risk, you get things like family violence, domestic violence, child maltreatment. We are all one or two stressors away from hurting people in our families, right? We imagine it sometimes as something that happens over there. As human beings, when human beings get stressed out, right, they're at risk for violence. So what would you need to add? For those families, we failed here. Well, now we're in tertiary service needs, right? And we're dealing with things like in the economic sector, things like, now you've got homeless folks and you need services around homelessness. For example, permanent supportive housing. Now there's been family violence. You need child welfare services, right? There are folks that are now, really having a hard time economically supporting themselves, and you need programs like general relief. In education, now we're in the mandatory parent education and anger management services that we so traditionally prescribed our child welfare families. Or, you're going to need your probation schools because you're going to have youth on probation because we have failed to make communities healthy. And in the unhealthy communities, we have failed to prevent harm. Okay. And what might you need to add? Health and mental health. Well, you might need forensic hubs that investigate, that support the investigation of child maltreatment. You're going to need pretty intense psychiatry medication management for folks that are experiencing significant mental health issues that are a result of homelessness. They're often a cause of homelessness also, but are also a result. Neighborhood and lived environment. Well, now you need foster care, for example, and transitional housing. I know we get really excited about, well, hey, at least we'll find transitional housing for a child aging out of foster care, but we're way downstream now, right? We are now in the business of preventing further harm after harm has already occurred for those that we failed to protect earlier, right? And lastly, in social community, what are you going to need now to add to your primary and your secondary tiers? You're going to need domestic violence services. You're going to need commercially sexually exploited children programming, or CSEC. You're going to need post-adoption support. You're going to need family finding. These are all things that folks in child welfare and probation are used to. But I show them these things to you in this order to say that while this is where we traffic for the most part, if we keep focusing here, we're just going to get more of this. Right? And again, that's job security. That's not what we're after all. Right? We'd like to prevent these families from getting to us in the first place and needing these kinds of services. Right? So, in order to have such a comprehensive prevention services program, right, and FFPSA will pay for some of this, right, particularly, the things that are needed on this slide, it's not going to prevent it's not going to pay for much of the stuff on the prior two slides, right? However, you've got partner agencies that are already providing primary and secondary services now, right? So, and they've got funding. So this is not comprehensive by any stretch of the imagination, but you can start to see there are these funding streams available in these determinant areas that your partner agencies have access to, but they're going to have to be at the table when you're doing your cross-sector planning and your asset mapping and your service inventories, because there's stuff that the folks in traditional probation and child welfare area, we may not know about these, right? But we might be able to braid some funding to partner on funding certain community-based organizations, so we can have a full comprehensive prevention services system, right? So I'm about to show you, I'm about to show you child welfare funding that we can bring to bear with regard to funding things that Family First may not fund, right? And some of this funding is available now, right? And it can be used while we figure out automation, while we figure out how we're going to do claiming and reimbursement. So I'm going to, again, this is by no means exhaustive, and you'll have this to review at your leisure back in your county teams and your agencies. But so we've mentioned some of these already. So there's, and if these numbers, so for example, this first column where it's the FFTA transition grant, Don talked about that earlier, and we'll talk about that a little more in a minute in terms of what's required of us to be able to access these funds. Don said 49.1 million was California's allocation. So that 43.8 million doesn't match that number because there, as is our custom, there's a CDSS holdback to be able to administer these funding programs, and so that's why you see it's 43.8 and not 49.1. So then you've got your FFTA funds, your transition funds, and I'm going to talk about this in detail here soon. You've got your share of a state block grant that without it ends up being about 199 million after the holdback, but it's your share of that 199 million of state general fund money that you can have access to if you submitted a letter of intent to CDSS by April 30th. Then there are American Rescue Funds, the ARPA CB cap, right? And there's your share of that. There is Ffpa, but like I said, it's going to take us a minute to get that up and ramped up. You heard from Don, it takes time for folks to start to claim, but we've got these others that we can use in the meantime. Here's some more funding streams. You've got your county children's trust. You've got your local revenue funds that support both probation and child welfare activities. You've got your 4B subpart 1, PSSF, CB cap. And then your CAPTA funds, American Rescue CAPTA funds, your state Children's Trust Fund, and there are CB cap grants. So again, this is likely not exhaustive, but it gives you an idea. There are several threads. If you think back to one of Don's earlier slides, like there's several threads that we can start to braid together, and we can start to do it now. So let's talk a little bit about, let's zoom in on the Transition Act. So we're gonna drop links to these county letters here. But in terms of those, and many of you are holding, rightfully so, holding on to your transition funds to really be strategic about how you want to use them. But here are I want you to have the reporting requirements, right? So CDSS is required to include annual updates of the use of any transition or certainty grant funds. Don mentioned both of those, starting with the APSR that's due to the federal government June 30, 2022. In order for CDSS to submit that information, your APSR had to go to CDSS by February 1st, 2022 for the expenditures, if you had any. For the most part, folks haven't expended many funds, so this hasn't become urgent for you yet. It might become urgent the following year. Similarly, there are other reporting requirements for FFTA that you should know about. So what are you going to need to report? How funds are used to implement parts of FFPSA. If they were used that way, details of all the programs and services and operational costs for which you use this grant, the characteristics of the families and children you served, and any previous 4E waiver demonstration counties will also need to report these things: the amount of funding they use to continue the activities, how they plan to transition these activities sustainably, and what are the funding source that were used to cover costs for things that weren't eligible for 4E payment. And we've dropped a link to this one too. California has added some requirements around FFTA reporting, and those are that you need to use 50% of your transition grant funds to engage in prevention and early intervention planning, or expand capacities for evidence-based practices, or any evaluation activities, should you want to do them, with regard to setting up a prevention program that's related to FFPSA Part 1. And you can do what does that look like? It looks like readiness assessments or gap analyses. Oh, things that you're gonna need to do anyway to start to submit your comprehensive prevention plan, and to assess strategically where you're going to allocate resources. So you could spend it on those assessments. You can spend it on building local capacity and infrastructure. You can continue or establish, continue, or expand prevention and early intervention services. You can evaluate evidence-based practices that you'd like included in the prevention services clearinghouse, or like to raise their level of evidence from promising to supported to well supported, any transition activities. And after dedicating 50% of those FFTA funds for these activities, then counties or tribes can use FFTA funding for any activities to support all parts of FFTA. FFPSA. Part 1 is the prevention part, but there's Part 4. If you weren't in California, you might Kinship Navigation. That's not part of our prevention plan now. It is being worked on, but it's being worked on in another part of the agency at the moment. All right, so that's what you need to know about using your FFTA funds. All right, so. But sort of most importantly of all these funding streams, or most important rather, I would say, is the state block grant that was made available by the passage of AB 153. Okay, that's your share of, if you look at that last bullet, 198 million that are allocated to counties who intend to opt in. And your intention to opt in was documented by a letter of intent that you were going to submit to CDSS by April 30th of 2022. And here's how it shakes out with regard to the allocations for child welfare and probation. So In addition to that letter of intent, which essentially turns on the state block grant spigot early, and I'll tell you what I mean by that in a moment, you're going to need to start working on, and you can use the funds to do this, building a 3-year comprehensive prevention plan that has primary, secondary, and tertiary services and strategies. I just showed you those. Right? That plan is due January 31st, 2023. Okay, so if you opted in and sent a letter of intent, you will continue to receive state block grant funds past January 2023 if you submit a CPP, as we're now calling it, Comprehensive Prevention Plan. If you choose not to submit, you choose to opt out at that time, or CDSS does not get a plan from you, you won't have to give back what you use today, but your funding going forward will be reallocated to the folks that stayed in. All right. That plan is going to, you are going to have to estimate, talk about your plans for a 4E service strategy. All right. So AB 153 fully intended to make sure that we don't just go ahead and work on the primary and secondary because FFPSA is too complicated, right? We do, it was intended to really make sure that folks did the whole arc, right? The primary, secondary, and the tertiary 4E funded services. These services do have to, and you'll have to show how they're culturally appropriate and responsive to meet the needs of the families you have that are disproportionately represented in the system. These are some of those categories. The services are potentially claimable as it stands now, retroactive to October 2021, if anybody's provided them and tracked them since then. And, you know, there are the amounts I've already mentioned now. Okay, so your share, and we've dropped links to the policy that gives you a little more detail on what's available from the state block grant. I'm going to go a little bit further into what the elements of this comprehensive prevention plan need to be. All right, this is straight out of the block grant letter that you now have a link to. Outcome of any asset mapping, needs assessment, and capacity or readiness assessments. It doesn't say which, it just says any. Okay, there are tools available and there will be guidance forthcoming about ways to do this, but it's not prescribed. Right? It's if you have hired your own consultant and they have a particular way to do asset maps and it gets you where CDSS intended to get you, use that one, right? But what are the outcomes? And you know, we'll go into the modeling, like how do you look at services and what you need? How do you look at your population and what they need at an upcoming webinar? We'll go really into detail about what kind of analyses you might need to perform across your sectors. Okay, so outcome of any assessments, right? The rationale for candidacy and service array choices, right? I've highlighted that in this gold color because that is directly related to what you're going to have to do in the fiscal and funding area, right? You're going to have to model all of this based on these assessments and then come up with your rationale, you know, and then run it by the fiscal folks to make sure you can afford it, right? And then provide your rationale for candidacy and service array choices, okay? You're going to need to provide a theory of change and a logic model. What Claire showed you from the World Health Organization report is an example of a logic model. There are, again, you'll have some guidance and technical assistance from CDSS and you know, this learning series with regard to those, but it's not a prescription on which logic model typographic you're going to use. It just has to be a logic model. Okay, you may already have one, some of you that have been working on prevention for a while. Okay, how are you going to use the integrated core practice model across prevention? Right, your strategies for expanding your use, enhancing your use of ICPM is going to need to be in there. The description of this governance approach that I pointed to earlier, and we're going to go way more into at our upcoming forum, but you're going to have to describe this governance structure. You're going to have to explicitly describe your efforts to engage tribes. You know, depending on how you set up your governance approach, right? If you had set it up in a way where originally there wasn't a mandate to include tribes, you may want to add that now to whatever governance structure you're thinking of using. And then there's some assurances, because how this is all going to work and how we're going to automate it is still in development. But assurances, right, that you will provide training and workforce development inside of the requirements that will come forward, both for things like candidacy determination and safety and risk monitoring, but also things like EBP service provision. CQI assurances, which include that you'll provide these services when applicable with model fidelity. So this applies very specifically to evidence-based practices. And we're going to go into that in an upcoming webinar in detail, and how you think about model fidelity. Then there's going to be assurances around it that the 4E agency is not going to abdicate its role around safety monitoring and risk assessment, right? And you heard about the community pathway that Claire talked about. We're going to have to sit down together and think about with CDSS and based on conversations with the federal agency, how can the 4E agency not abdicate its responsibilities around that, but provide a way for the community-based organizations to do some of this. So a family has at least contact as possible with the child welfare system, the formal child welfare system. And then another few gold ones that are directly related to the fiscal and funding conversation. What's the spending plan going to be after you tell me who your candidates are and how many there are and what service array you've chosen? What's going to be the coordination with your mental health plan specifically? Right? And I know that CDSS and DHCS, still need to finalize their coordination, and some of how you finalize yours locally depends on that. However, it doesn't hurt to start talking. And then what is your sustainability plan? Let's learn from some of us had some hard learned lessons from the 4E waiver, where when the waiver ended, what we thought was going to be a sustainability plan was inadequate, right? And we had to scramble at the last minute. So now, I don't know that there's going to be transition fund, future transition funding. So how are you going to sustain these services beyond the 3-year plan? Because this is one-time 3-year funding, the state block grant. So those are elements of the CPP. I'm not going to go through all of these, but these are the allowable activities that you can use the state block grant for. I'll just point to some. Look, administrative costs to support prevention services delivery. Administrative activities to expand prevention services. Piloting EBPs. There's one more slide on this. Direct services beyond those in the ACF plan. So, example number 3 that Don showed us, where we all went, oh, that child wouldn't be eligible for either traditional candidacy or FFPSA candidacy. Well, then perhaps we should figure out who those children are in our analytics and make sure that we're using our state block grant to provide them with services, equivalent services, services that have parity. We've got to remember that just because we're using state block grant funding for an EBP, it doesn't mean that we don't have to provide it with the same level of fidelity that we would have if the feds weren't watching, so to speak. All right. And then just want to point you to, and we'll send you a link. We'll send you a link to these. These are the links to the county fiscal letters that followed the state block grant. There's one that shows how the allocations were made, and then the subsequent one has how to claim and claiming codes, etc. Right. So I'm going to stop there. Right. It's a lot, but you have this all at your fingertips now, all in one place. Right. So, our child welfare directors and our behavioral health directors and our probation directors can start to have conversations with their fiscal folks, like real concrete conversations about, okay, so what are we going to do with whom and which populations and which services, right? So this is intended for you to get you positioned to have those conversations. There are still many open questions, but like I said before, it doesn't hurt to start talking. So with that, I'm going to end my piece, and I'm going to turn it back over to Don for some closing comments.
Great, thank you, Cush. So next slide. So this slide, now this is somewhat oversimplified, and feel free to make it more granular. But if you think about system change and what you're embarking on with Family First, one of the things to make sure is that you build in metrics to know when you're successful. And so, for example, you may want to take note of your caseload today. Where are the children that you serve today in these categories? How many are in the prevention services? And that may be 0 under the new prevention services dynamic. You've got in-home cases, you've got family foster care, you've got kids in congregate care. You may want to, depending on your local goals and focus, you may want to, for example, take the family foster care row and divide it into relative care and non-relative care. For the congregate care, you may want to set up rows for each of the specified settings under Family First, depending on what your needs and your focus. But what my advice, at least, is take note of where you are now, and then say, suppose we're successful. When we are successful, what will this look like 5 years from now? And build in a pathway so that as you go forward, you see, are we making progress towards what we wanted to see? There are many, many intervening variables that could come up, but at least have a sense going forward, because what you don't want to do is end up 5 years from now with more kids in out-of-home care and a bunch of kids that you're serving in prevention, but that aren't really preventing entries into care. So you can make this more discrete, more concrete, but at least take note of what pathway are you on to get from where you are now to the future. Next slide. So a couple of just closing remarks. First of all, remember, prevention plan approval is the beginning of a process. So once the state gets approval from the feds for their Family First Prevention Services plan, then there's a tendency to think, aha, we're done. No, you're just getting started, and keep that in mind as you go forward. Next slide. So the recipe for success is pretty straightforward, and this is somewhat generic. It may be different in your county or in your jurisdiction, but essentially you want to safely prevent removal. If that can't happen, often a fit and willing relative will be a good first option. And if that's not possible, then family care would typically be preferable where that can be provided. And even in situations where therapeutic support is needed, that can certainly be provided in a family setting when needed and when appropriate. And now moving into Family First, you would want to just provide facility-based or congregate care when that's clinically necessary and only for the duration that it's clinically needed, and then providing supports to accomplish reunification or other permanency outcomes such as adoption or guardianship as rapidly as possible, and provide where appropriate and where indicated post-permanency services and supports. Next slide. So I started off with a slide that showed a tangle of yarn. Hopefully this tangle is not too daunting, but many jurisdictions, as they move into Family First, have found that the technical aspects of implementation very much impact their ability to successfully claim Title IV-E for prevention services. So things like your cost allocation planning, things like your claiming systems and your reporting systems are things as you prepare for Family First to pay a lot of attention to, because those are the things that when you get to post-implementation, you're going to find are challenges that you need to think through and conquer as soon as possible. And finally, next slide. Many jurisdictions have used Family First as a catalyst for positive change and building a system to improve prevention and family well-being. If you think of Family First as just doing what we've done in the past and overlay these new requirements, then I don't think you're going to get the maximum benefit. Think of this as a catalyst for change. How can we use this to retool our systems to fully embrace our ability to prevent entries into care, but to build a system that focuses on child and family well-being into the future? If you do that and use it as a catalyst for change, then that's going to get the maximum benefit. And I think next slide is back to I think Dana or Cush.
Yes, it is. It's actually back to Jess, and I'm going to keep advancing the slide. Thank you so much, Don.
Kush, we are actually going to open this up for Q&A, which I believe you are moderating.
Ah, yes. Okay.
And I think that
okay.
You are going to have a list of questions that people have teed up in the question and answer. And while Kush is taking a quick look at those, if other people have questions as you've all been listening, and you have additional questions that you feel like weren't answered, or you'd like a little bit more explanation for, do feel free to drop those in the Q&A box now. If we don't get to them in the next couple of minutes during the Q&A session, they will be included in preparation for the Q&A session on July 13th, and we'll be dropping a link for that registration shortly. But we are going to take some questions now from the Q&A.
Right, here we go. So I'm gonna read the questions, and then Claire and Don, I might be sure about some of them, like who might be most appropriate to answer which one, but feel free to just say I'm going to take that one also.
Absolutely. Right. And I've been answering some of them in real time, but we can put them out for dialogue as well.
Yeah, absolutely. And we've got some time, folks. So, we've got 23 minutes to be able to ask some questions. And there's good, we'll talk about this a little more later, but there are going to be Q&A sessions that follow each webinar that are sort of more interactive, where we will be taking questions that this generated and having a more interactive forum to answer those with the speakers that spoke at the webinar. All right, so here goes. Is a report to child welfare a necessary but not sufficient requirement for candidacy? The question doesn't say which traditional or FFPSA, so you may want to answer for both. And Don, you want to take that one?
Sure, I'll start, and then Claire can correct me if I get it wrong. So for traditional candidacy, the traditional policy has been merely having a report alleging abuse or neglect or finding of abuse or neglect is not sufficient to establish candidacy, that it has to meet one of those other criteria that I went through, be listed in a case plan, that the absent effective prevention services, foster care would be the next step, or the eligibility determination or court order, whatever. So all of those would have to be met for traditional candidacy, and a mere report would not be sufficient. For family first candidacy, however, it's governed by the state's prevention plan. So there is a broader ability. The state in the prevention plan proposes a definition of imminent risk, and that can be broader than the traditional definition, and states have significant flexibility in how broadly they define imminent risk, and therefore who can or can't be a candidate. Claire, is that right?
And Claire, I'm wondering if you can kind of come off mute and just say a little bit about, well, but you will, there might be child abuse reports that you might look at to determine candidacy. Like what kinds of things might you be looking for with regard to hotline screenings or things like that could be part of how you choose to look at candidacy. I know there are some analyses. Could you just speak to some of those things that you could use child abuse reports for?
Sure. I'm going to anchor this first, though, in Don's answer and in PI 1809, page 7, paragraph 3, which says that the federal government will not further define candidacy or imminent risk, right? So we've said that a couple of times here, but it's important to frame any answer to your question in that. States are taking a variety of approaches to defining candidates, with some requiring that the family be known to child welfare, and the traditional way that families become known to child welfare is through a hotline call, right? Some are requiring that, that there be an investigation and some sort of substantiation, while others are thinking more broadly. We have a couple of examples of states that have proposed families who are receiving Healthy Families America to be categorically eligible to receive Family First services, so that they meet the risk criteria set forth in a service process. So I think we've seen this sort of very broad array of ways in which states are thinking about candidacy. So if very specifically to answer your question, if you're going to say everyone who's called into the hotline is a candidate, or some subsection of families that are called into the hotline, I think you'll want to do the same kind of analysis that you talked about early, right? Am I looking for families where substance abuse is a concern, or the need to prevent substance abuse? Remember, Family First provides the ability to deliver substance abuse prevention services. Families where mental health needs exist, or there is a need to provide mental health prevention services. Families where parenting and the need to create connections to resources that can support skill building in the parenting realm are things that you might want to be looking for. If you believe that one or two or three particular EBPs are going to anchor your prevention plan, you might look for families that that are called into the hotline that meet the criteria, that are the target populations for those EBPs. So there are a number of different ways to approach it. Making the decision is the first step.
Great. Thanks, Claire. All right, next question. Is quote unquote family settings referring to the parents or parents and relatives? And there's a sort of a follow-on question which is, if a child is living with relatives and not parents, but not in foster care, could they be eligible for prevention services?
Yes. Yeah, and if the child is not under the placement and care of the 4E agency, then they're not in foster care, and they could be with a parent or they can be with a relative. And the relative, the definition of relative can include fictive kin as well as blood relationships.
Excellent, thank you. Next question. What do most counties use for a match? Or you could say, like, where do folks usually find their match? What can you use as a match? What can't you use as a match? And we have a Mental Health Services Act, and you probably can't speak to that, but that's part of this question.
Well, so match for Title 4E, so the basic requirement is that it has to be non-federal funds. So it can be state funds, it can be local funds, it could be realignment funds. It can. The restriction is that it has to be under the control of the public agency, and so but state or local funds, it can't be used currently to match any other federal funds. So if you've got funds that are used to match some other federal program, then you can't use that. But other than that, state or local funds that are non-federal can be used. There's some exceptions for tribes that go a little further, but that for state and local agencies, that's the basic rule.
All right, great, thank you. Next question. Please help spell out FMAP rate. You do a tutorial in 5 minutes, Don, on FMAP?
Oh, certainly. Federal Medical Assistance Program, or Federal Medical Assistance Percentage. There's actually a formula in federal law, but essentially it's based on per capita income. So if your state per capita income is less than the U.S. per capita income, then you would get a higher FMAP rate. If your state per capita income is higher, then you get a lower rate. So it's inversely related to state per capita income. The norm, if your state per capita income was exactly the same as the US per capita income, then it would be 55%. So 55% federal, 45% state. However, there is a minimum in statute of 50% and a maximum of 83%. Although currently there is an additional 6.2 percentage points because of the public health emergency. But so currently California is 56.2, but normally outside of public health emergency would be 50%, which means that California's per capita income is higher than the US per capita income. Therefore, its match rate is lower, but you can't go below the 50% floor.
Thank you. It's even less than 5 minutes. Okay, the next question. So what's the expectation for 4E/FFPSA funding with, say, clients who are getting services from the regional center, right? So those are funds that are behavioral health, developmental disabilities. So how will FFPSA interplay with things like that?
Typically, and I'll speak kind of generically because there's some details that could come into play, so I could come into there. But typically, when you have a regional kind of center, typically you would have a cost allocation plan behind that for the administrative funds that would dictate, which programs benefit from the existence of that center, and then you would allocate out the administrative cost to that, and would typically be how it would work. So within that, you would amend your cost allocation plan to account for how are you going to measure the extent to which those activities benefit Title IV prevention services, and then cost allocate that portion to that. There's some other ways that it could work, and when you get into the details of cost allocation, it can get a lot more complicated, but that's the basic concept.
Thank you. Does MOE, next question, does MOE include county dollars that exceed the required match?
It would depend. The MOE is a very simple concept, but calculating it is not so simple, because the first question is, so first of all, if you're talking about the 4E program and state match for 4E program, no, that doesn't count. But if you're talking about state funding above or beyond the 4E program, it would depend. The language out of the federal law is expenditures for foster care, prevention, and services and activities under any state program that is not TANF, 4B, or SSBG. But to be countable towards MOE, it would have to meet all the criteria for a prevention service. So in 2014, was there a state program, and did it serve families that were at imminent risk according to the criteria, and were those evidence-based and trauma-informed, et cetera, et cetera? So you would have to apply all of those filters to it to determine whether or not it was countable towards the MOE. Many jurisdictions, when they apply all those filters, find that the MOE is less than they thought it was going to be. But technically, state program, local expenditures on state programs that meet all those criteria could potentially be part of the MOE calculation.
Great, thanks, Don. Claire, I'm going to throw this one to you. Can you speak about how motivational interviewing is used or claimed as an FFPSA service in other states, whereas it's used as a cross-cutting service?
Yeah, absolutely. And there was a second motivational interviewing question.
So let's lift that up too.
Let's do both.
Yep.
So some states have described early on using motivational interviewing as a cross-cutting intervention. Much of the feedback from the Children's Bureau was sort of quizzical and asking back, is that a mental health prevention or treatment service, a substance abuse prevention or treatment service, or a parenting service? To which we've really encouraged states to respond that they're using it for all three. And so motivational interviewing is a highly flexible service that can be provided by individuals who are trained. They are not required to have a graduate clinical degree to deliver this service. So it is being applied often through the workforce in child welfare, that is becoming integrated into part of the day-to-day practice with families, and a strategy to really, and I said this earlier, redesign the family user experience of child welfare so that the case management service becomes oriented around family motivation, family goals, and creates the context in which families can tap into their own wells of strength and motivation to make progress or to achieve the things that are important to them, which is a vastly different framing of child welfare practice historically. It is also being used through the community pathways, is how many states are framing this up as well, so that those community-based entities, organizations, family resource centers, through which a contract for providing case management or supports to families and family first services, that motivational interviewing would be integrated as a core component of that service delivery as well. So another mechanism by which we can resource community-based organizations and communities to serve families very differently. A prior question asked sort of the same question, and in the Q&A list, there's a link to a recent brief that we wrote at Chapin Hall on the use of motivational interviewing and considerations that might be helpful to you.
Yeah, and if I could jump in on that
Please.
also, that from a fiscal perspective, and in addition to the clinical benefits and the service benefits from motivational interviewing, remember we said that to be a family first candidate, you had to have a child at imminent risk who was getting a prevention service listed in their prevention plan. Well, if every child is in a family that's getting motivational interviewing, and every child who is a candidate has motivational interviewing entered, and it's a well-supported program, then every child who's a candidate becomes a family first candidate rather than a traditional candidate, regardless of what other prevention services they may get. So it is something where there is a significant fiscal impact, as well as the clinical and service provision impact.
Yeah. One other really important point about this, I think, as well, we see in the literature and in some states that are beginning to implement more clinical based EBPs, that historically we have seen great difficulty in getting families to EBPs, getting families to participate in the EBP and to stick with an EBP over the course of the EBP. Motivational interviewing helps to alleviate that problem. So for example, if a family likes the EBP, but they can't make it for 2 months at a time, there's some claiming questions there about, can I claim during the month in which an EBP was not provided? But if motivational interviewing is being provided by the person who's most closely attached to the family through support or case management, and that motivational interviewing is being provided every time that person sees the family, that creates a very different context in which claiming is possible.
And Claire, correct me if I'm wrong here, but in order to provide motivational interviewing, while you don't have to have a clinical degree, you do have to be certified to provide it, not just went to a training and do a little bit here and there based on what I heard.
Absolutely, Cush. That is it. You can't just stand it up tomorrow and say we're providing motivational interviewing. There is a rigorous training and certification program and fidelity monitoring, as with all EBPs. Many of those considerations are discussed in the brief. But yes, that's exactly right. And as we would absolutely want it to be.
Great, thanks. Okay, let's see. Yeah, Claire, this may be you as well, at least starting us off. Can you provide more details regarding sort of family stabilization funding and concrete support pilots?
Sure.
Or at least the ones you know about. I know that we've got a couple going in California. So you probably can't speak directly to those, and it's certainly not my area of expertise, although I've seen the grant, the RFPs and the grant requests sort of go across in the listservs I'm in. Yeah. But in general, like there's concrete supports, and you have been at the forefront of sort of raising them up. And I think Indiana Can you speak a little bit about sort of Indiana's approach?
Sure, absolutely. So first, I'll start by saying that there is a growing body of science around the provision of economic and concrete supports and its associated relationship with reducing child maltreatment and involvement with child welfare. We'll drop a link to a survey of that evidence into the chat so that you have it. Many states are starting to think about how do they begin to stand up pilots to provide direct cash transfers or stipends to families, working through benefit cliff issues so that families don't lose other benefits if a stipend or a cash transfer is provided. There are at least 2 learning collaboratives that I'm involved with currently that are very explicitly working towards with much more intentionality, better deploying the social safety net and providing economic and concrete supports to families across a variety of things, like looking at EITC take-up. It turns out EITC matters. Looking at, we've just seen New Mexico create universal childcare for a year for families under earning under $100,000. So I think many states are starting to think about economic and concrete supports far differently than they did. In child welfare, we've often concerned ourselves with child welfare policies and not with macroeconomic and social safety net policies that have seemed outside of our wheelhouse. But I think the evidence suggests quite the opposite. And it's exciting to see states and localities begin to test what that can look like. The Stockton randomized control trial in California is very powerful. And while they did not look at child welfare outcomes specifically, we certainly see more access to economic resources and stability in the household, and as well as more employment post the pilot than before the pilot. So really interesting evidence emerging and new action across the country.
Thank you, Claire. And thank you, Dawn. We are out of time, but I know this is not going to be the last time folks get to ask you questions. So I'm going to transition it back over to Caltrin. And just, again, my deep thanks for just what you're able to provide and how clearly and succinctly and simply you're able to convey this very complicated information, the 2 of you.
Thank you so much. I want to continue this thank you train by thanking Casey Family Programs. Just thank you for sponsoring this event. Thank you, Informatics and CDSS as partners, and for the wonderful information that you provided today. I want to tell participants that if you had some questions that may not have been addressed, if you want to know more in depth, have a longer discussion about this topic, there is a Q&A that's going to follow. You'll find that information in the chat that lays out all of the upcoming training and the series. As a matter of fact, I believe thank you. This is a series schedule to give you an idea of what is coming up. So the Q&A for this session happens on the 13th of July, followed by building the team, designing a comprehensive county prevention system, so forth and so on.